All right, so in today's topic, we're going to be discussing syphilis. Now, the reason why it's so important and why we should touch on this is because the USPSTF recently updated their guidelines to include universal screening of syphilis in the asymptomatic patient. Really, we want to target those who are at high risk. And the reason why we want to do this is because we've noticed data from 2000 when compared to 2014, and we've noticed an increase in diagnosing syphilis. It's been about doubling from 2000 to 2014. Now, those patients who are at high risk are going to be those who have HIV, those who are men who have sex with men, which will be abbreviated MSM, commercial sex workers, and those who have been incarcerated. We're also going to be looking at race, and we're also going to be looking at the patient's age. Now, when looking at race, we're going to be comparing African American males to Caucasian males, and African American males are going to be at an increased risk when compared to that of a Caucasian male. We have an incidence of 19 per every 100,000 in the African American population. We have 3 per every 100,000 in the Caucasian population. When we look at the age, men who are under the age of 29 have a 3-time more likelihood of being diagnosed with syphilis. So they're 3 times at risk, males who are under 29. When we look at the population of men who have sex with men who have HIV, half of these people are going to be co-infected with syphilis. So this is what makes a patient high risk. These are the patients who should be screened. Typically, we're going to be screening every single year, with the one exception: the population of MSM who have HIV should be screened every 3 months because they're at higher likelihood, they have a higher incidence of developing co-infection with syphilis. Now, the asymptomatic screening is going to be a twofold. First, we're going to do a non-treponema test, followed by a treponema antibody test. So the non-treponema test is going to be very sensitive, but it's not going to be very specific. This means it's going to catch a lot of positives, but all of these that are positive doesn't necessarily mean we have a diagnosis of syphilis. Now, the non-treponema test is going to include RPR and VDRL. If this is negative, then we don't continue the workup. We don't need the antibody test. If this is positive, then we need to order the antibody test because we need to make sure that this patient has syphilis, because we can also have false positives for a variety of other reasons. We have false positives, especially in pregnancy. So let's say, for example, we have a patient. We screen this patient with the non-treponema test, which will either be the RPR or the VDRL. If this is positive, then we order the antibody test. So this is going to be the treponema antibody test, and we have 2 types of antibodies that we're going to be ordering here. We have the FTA, which is a fluorescent treponema antibody, or we have the treponema pallidum particle agglutination test. So these are 2 antibody tests that will confirm the diagnosis of syphilis. So if we have a positive RPR and a positive antibody, now we have a diagnosis of syphilis. If we have a positive RPR and a negative antibody test, then this simply means we have a false positive of the RPR. Now, we have to keep in mind when looking at the RPR or the VDRL, we're going to be given a titer. Titers over time will start to decline even in the patient who was never treated. Antibodies will remain positive for life, even if the patient was treated. So the RPR may or may not stay positive for life, but the titers will decline over time. And a low titer is considered to be that of 1 to 8. So 1 to 8 and below is considered a low titer. Now, if we have a negative RPR, and we are concerned that this patient may have syphilis, then it's advised to do repeat testing 2 to 4 weeks later. The reason being is if you do the screening test too soon, it can have a false negative, meaning it just hasn't been enough time for the test to become positive. So if you have a patient in front of you who has all the risk factors, who is concerned of having syphilis, and we have a negative RPR, then go ahead and repeat the test 2 to 4 weeks later. Now, the CDC also recommends the reverse, meaning they recommend or they advocate for doing the antibody testing first, followed by the non-treponema testing, meaning do the antibody, and if this is negative, then we don't need to worry about infection. If it's positive, then the next step is to do the RPR and the VDRL and to look at the titers. Now, if we have two positives here, then we have the diagnosis of syphilis. If we have a positive antibody test but a negative RPR, then this means, depending on the titer and the history, that this patient had syphilis in the past and was simply treated. If we have a high titer, then this patient was never treated and you should give penicillin. If we have a low titer, it was treated and we don't need to worry about this, especially if they give you the history of being diagnosed and being treated with penicillin. Now, the other scenario is if we do this reverse order, we have a positive antibody, we have a negative RPR, we should be looking for signs of infection. So if they don't have a history of syphilis, they say they were never diagnosed, but we have this positive antibody, this could either be a false positive, which can happen in leprosy and malaria or other spirochete infections, or it can be that the patient is in a latent stage of syphilis. Because remember, the titers will wane and the titers may even disappear altogether. So if the patient had syphilis many years ago, the RPR and the VDRL can become negative over time. So positive antibody, and we have no history of being treated for syphilis, then we need to look for signs of infection, look for ulcers, look for rash. If this isn't present, then order a second type of antibody test. If this is positive, then we treat. If this is negative, no further workup needs to be treated. Now, if we're worried about being reinfected, if, for example, we have a positive RPR, we have a positive antibody, they've been treated in the past, how do we know if this is simply the old infection? Because as we remember, antibodies never disappear. The RPR may stay positive for life. How do we know if this is new infection or if this is simply a treated infection and the antibody and the RPR never changed? So we're going to be looking again at the titers. A fourfold increase in titers means we have a new infection. If we have titers that have stayed the same, especially if it's 1 to 8, this means that it's not a new infection. This means that it's been treated properly and we don't need to worry. Remember, the USPSTF wants you to screen those who are at high risk, especially if they're asymptomatic, and the high risk population is going to include patients who have HIV, men who have sex with men, incarcerated, and those who are commercial sex workers. So that's today's lecture. If you guys have any questions at all, please send an email and I'll see you guys on the next lecture. Take care.